John. Recordings in progress. Hello, everyone. Let me see if I see anybody. Attendees. There's only one attending so far. Oh, they're all coming on. Sarah Byrne, Monica, Chris, welcome, everybody.
And we have this one too, which I don't
Perfect.
know if.
You think they can hear me?
I think so.
Oh, I'm up there? Okay. Let me go back here. Let me get rid of this. Get rid of this. I'm gonna put on the, they're coming on, so that's a great thing. Let's go over here. Go to slideshow.
Let me give you a ring back in 2 seconds. We're just gonna call this way.
Audience question and answers. I don't think we need that. What's on the screen? No. Okay, let's get rid of that. We're not starting. Let's go to. Okay, perfect. Let me go back here.
Hey, Chris, just wanted to double check. Can you hear us okay?
Okay.
Yeah. Are you plugged in? Oh, sorry. Are you plugged in?
Where's Zoom?
I thought I saw Chris on it. Yeah.
Here we are.
All right, I'll log in. I'll test it out. Just say it, make sure.
Here we are. Perfect.
Awesome.
Okay.
Yep. Hey, everybody, it's Chris from Integrative Therapeutics and the Greater Boston Functional Medicine Group. And we're here at Kathleen O'Neill now, her office in the south end of Boston with all new toys and great things to keep people healthy. And just want to say thank you to all the people attending tonight that are here in person and the people that are on the call as well. We wanted to get things rolling so Kathleen can get started. And she's obviously been a great practitioner in Boston for many years now and worldwide. She's spreading the good word of longevity and how to keep people healthy and thriving for long into their 80s and 90s and maybe even over 100. So I wanted to introduce her and just let you know that how much I appreciate you. Fantastic. You've helped me as personally and professionally, and I appreciate that. And just wanted to kick it off and let her do her thing and educate you all and give us some great information. So here's Kathleen.
Thank you, guys. If only we could grow taller, right? Right. I also want to welcome Dakota, who came. I know that there are people here who have biochargers, but he came just because it's the most amazing company as well, just like you, Chris. And some other people, the Galeri, the foursome over here, talk to them. They're wonderful, and others. The other sponsors, John's here, Orthomolecular Lee is here, all the people who are here. The key thing I want to say is it's not about the length of the number of years, and you're going to hear a little bit more about that in this talk. It's really about the quality of those years, because I have no idea when any of you will succumb, and I hope it's long, but that's not what I try to do. I try to make sure that the present moment, the present day, and the days that follow are the best they can be. And in doing that, the goal is not to treat, I don't think of treating pathophysiology as we were trained. I think of treating aberrant physiology. So that's really one of the key things. These slides are a conglomeration of many of the people that I teach with. Some of the group at A4M, we've combined some of the longevity people, and we share teachings, events, different places, other cities, etc. So we do share some slides, which is why I don't feel comfortable really sharing the slides, but you're welcome to see the video as many times as you need. If they were all my slides, you could have them and use them and do whatever you want with them, but they're not all my slides. And I want to say thank you to the people that have loaned me, Dr. Raphael, Dr. Akey, other people who have loaned me a slide here or there that they pulled together that I learned from them, that I then integrated into my own decks. Okay? So let's move forward. Okay, let's figure this baby out. There we are. So tonight we're going to talk about longevity from, I think, one of the most fundamental spaces, which is the DNA. So we really want to understand the DNA and what happens to the DNA and how do we detect damage in the DNA and what do we do about the damage in the DNA? What are the causes? How do we detect it? And what do we do about it? Because the DNA are fundamental. So we're going to review telomeres, senescent cells, zombie cells, the SASP, the senescence-associated secretory phenotype, its role in biological aging, and any disease, all diseases. It doesn't matter which disease it is. It can be an inflammatory disease. There's only 3 types. It's inflammatory, it's autoimmune, or it's cancer. Every single disease pathophysiologically that you think of will fit in to one of those or be a combination of all of those with intersecting circles. And so we have to determine for the people that sit in front of us is what is their intention, first of all, and what do they want to feel, and then to be better. And then secondly, what physiology is not functioning best to treat the symptom that they present with. You can try to look at all the data you want, but changing data doesn't make a person better. It doesn't make the quality of their life better. What makes them better is knowing what they need and what they want to feel because they live in their body. Reviewing the physiology of the DNA damage, etiology and repair mechanisms, understanding why and how to treat at the most root cause, the most upstream etiology with regenerative therapeutics. Another colleague and I started the American Academy of Regionology. That's one thing that we care a lot about, which is a compilation of any field. It's the interaction and the intersection of all things, cardiology, gastroenterology, neurology, you name it. It's all because they're all interconnected. You cannot separate any one system. And the goal is to determine the optimal point of intervention to extend healthy lives, I don't know the age, and to heal diseases, not simply treat the symptoms. There have been many theories of aging over the days. They go on and on. There's been the mitochondrial, the entropic, the vitalist, the hormonal, the free radical. There's not just one. And that's really important. Whenever we get zoned in on one thing, we have to go back to 40,000 feet and say, what have I missed? You can always zone in if you're comfortable, but you must zone out to really understand, have I really addressed what might be the issue? Because I believe that there's a lot of mysteries that sit in front of me within these people, and I have to really zone in, zone out, zone in, zone out. What am I doing? What do they need? Why did they come to see me? And how am I going to fix them? So in terms of the theories of aging, and I've read those thick textbooks on that, I really think that everybody's unique. Everybody's a unique blueprint, and everybody needs you to approach them in the way that you can with your own basic knowledge, but then to expand that knowledge. That's a dog next door who's not happy. Probably alone and looking for company because it's all about the relationship between us and the relationship between the organs, right? That's why regionology is really interesting to me. But the question that we always have to think about is where are we going to intervene? And I really love the telomere medical, and I love looking at telomeres, and I came to telomeres, I don't know, a long time ago. Somehow I ended up learning about telomeres, and I remember speaking to companies that have been involved in telomere health for over 25 years. And one of the particular doctors, Dr. Maria Blasco, runs the Children's Cancer Institute in Madrid. And so somehow I end up on the phone with her and I go down rabbit holes, but then I come back and say, how am I going to use it? So that's been a good 25 years. And she's been involved in many of the studies of telomeres, along with Michael Fossel from Stanford originally. And then there's a lot of work here at Harvard as well on telomere health. They are the DNA structures. You know what they are at the end of the chromosomes. How many people know what a telomere is? Yeah. The Gallieri people know. That's a good thing. Because if we don't know about that, we're in trouble, right? And those are the cancer Grail people. I think it's Gallieri and I call it Gallieri. I put my little Italian non-accent on it. But telomeres control cell aging, and they control, how well a cell can replicate, divide, heal, autophagize, become apoptotic, and how well it can communicate with the cells around it, just like the puppy next door wants a little bit of love. So cells need love, cells need touching, they need to be touching soft spaces. In order for stem cells to grow, they need to have a substrate that is malleable. It cannot replicate on a hard space, and that's pretty intriguing. So the cell aging causes aging itself, which is quite remarkable. This is one of my favorite slides. I love really complicated slides because if I can understand them, then I think I know what I'm doing. But if you start in the middle with DNA damage, I think it's pretty simple. There's 3 things that relate to DNA damage: DAMPs, PAMPs, and MAMPs. The AMPs is all the same, associated molecular pattern. A molecular pattern, kind of, this is what this is so great at, shifting the energy within molecules, protons, neutrons, electrons, you name it, because we're all about energy. That's a whole other lecture, but that I've done, not for these guys, but because I believe in energy. And we are all energetic beings, EEGs, EMGs, EKGs. We are all energetic. And if we fail to understand and know that, we've really missed a big part of it. Our energy, the patient's energy, back and forth, etc. But the DNA damage happens. I like to simplify everything. I love 3s: DAMPs, PAMPs, MAMPs, damage-associated molecular patterns, which are kind of alarmins, and they're things other than PAMPs, which are pathogen-associated molecular patterns. And so PAMPs can really cause pathogens, microbes, COVID, RSV, whatever microbe you want, Lyme, whatever your drug of choice or bug of choice is, can cause DNA damage. And then in addition, if you just think of it, there can be other damps that are going on, exposures to mercury, graphene, squalene, whatever it is in the moment. That's DAMPs, PAMPs, and MAMPs are microbiome associated molecular patterns. Just to make it so complicated, we'll never understand it, right? But that's okay. We love mystery. So DAMP in the middle, when we get DNA damage from epigenetic changes and chronic stress, sterile stress, not necessarily PAMPs, if either we get apoptosis, but if we don't get apoptosis, we end up with the zombie cells. We end up with cells that can no longer function, but stick around and do damage. We reduce the activation of stem cells, and we end up with the telomeres that are shortening because they are damaged. They are the damage detector. The more damage to the DNA, the damage detector, this telomere, shortens. So either we're lucky and we get autophagy. If we don't autophagize as well, we end up with other DNA molecular patterns that are happening, and you can see them here. And we end up with mitochondrial dysfunction, another theory of aging, right? And we all know the importance of the mitochondria. The mitochondria would prefer to live alone. We make it too complicated for them by increasing all the free radicals and the oxidative stress and not understanding our energy needs. And we can end up with cellular senescence or zombie cells. And then obviously there's metabolic dysregulation. And I think insulin and cortisol, in terms of the dysregulation, outside of all of the things at the bottom, the cellular senescence, the lack of autophagy, and the mitochondrial dysfunction, I mean, those are things that we can readily see at a high level. We can measure insulin and glucose. There's no need to ever look at a glucose with a stelo if you don't have any understanding of what the insulin is, because the insulin is awry, is not working appropriately way before the glucose is good. I'm talking decade before the glucose is going to be a problem. So if we don't know the insulin in our patients, it's really, and the A1C doesn't cut it. The A1C, even including head of endocrinology at the Brigham of diabetes, the A1C is an old measure that doesn't really cut it, but we're still stuck on that. I have patients with A1Cs of 4.9 or 5.1, which sound amazing, but they still cycle like this, and their insulin levels are high, causing their blood sugars to be low, and that's a big issue. And they are disease in the making. They are all of the outer circle on here that you can see, aging and age-related diseases. Pick your disease, whether it's cancer, a tumor microenvironment, whether it's an inflammatory disease like diabetes type 2, cardiovascular, chronic renal disease, or whether it's an autoimmune disease, right? So these are complicated slides, but just I love this slide because I love in the center, you know, I love fascia, fibroblasts, fasciocytes. I love the immune system, macrophages, lymphocytes, and you can see them all in the center. I love the extracellular matrix, which is also called the fascia or the interstitial fluid, or, collagen, whatever, however you think of it. But this is where so much is happening that's going to cause this disease that we see at the top of the tree, as opposed to thinking about where it happened at the roots. And this typically will result from the senescent associated secretory phenotype. And when the senescent associated secretory phenotype is expressed, and we have all of the cytokines released, and ideally adequate lymphocyte activation, macrophage activation, but most importantly, resolution. Activation's appropriate, but not chronic activation of these inflammatory cells and inflammatory cytokines that can't be resolved. Resolution of that is appropriate. Without resolution, we get fatty infiltration of every tissue. Fatty liver, fatty heart, fatty this, fatty that, fatty muscle, and etc. So all of these pro-inflammatory, these are attempting to clean up the SASP products, but they can't always. And then within the extracellular matrix, the fascia, you end up with dysregulated immunity, a microenvironment that is not a friendly microenvironment. It's a tumor of sorts, because you can call chronic inflammation a tumor-like environment, because you're going to get fibrosis and scar tissue and fatty infiltration. So it is a tumor microenvironment of sorts, maybe benign, maybe not metastatic or malignant, but effectively it's due to unresolved inflammation. So now let's look at the physiology. Here are the telomere, the telomere caps, and you can see that they protect the end of each strand of DNA, and we know that, and I think of them obviously like a shoelace on a sneaker. When that plastic cap comes off, it all unravels. No bene. We do not want the DNA to be unraveling, because what is the DNA about? It's about producing the proteins, etc., that heal our tissue. If that DNA is unraveled, we don't get appropriate protein proteostasis, and we don't get healing the way that we should. The shorter the telomeres, and there are telomeres obviously in every cell. The cells that I like to think about the telomeres in are the leukocytes and the lymphocytes, the immune cells, because those are some of the most important, and you'll see why. And they act as the damage detector, and they act as the clock that signals to cells age, time to age. We're already unraveling, let's go. And you can unravel at any age. It doesn't mean that your plastic shoe cap is, on at, it has to be that you're 60 or 70 or 80 years old. It can unravel at any age. It depends upon the library of exposures epigenetically that you've had, plus genetics, your unique blueprint, and how those. So here at conception, you can see on the left, and this is just a rough schematic, that telomeres are degrading over time with 15,000 at conception and birth, telomere base pairs on the DNA. DNA is base pairs. And by the time you're a teenager, and this happens also in the thymus gland, and you'll see that in the slides coming up, by the time you've reduced by 30% the length of your telomeres, and that's pretty significant. By the time you're 50, you're down to 50% of the length of your telomeres. Pretty dramatic. That's if you're just well. That's in the general population. But if you were the sick person, the 22-year-old that I saw this week, or the 25-year-old that I saw this week, they're probably a lot shorter, and by the time that they're 25, because they've been sick chronically. And if you're lucky at 80, you're down to 25%, right? So many of you hopefully know Leonard Hayflick in 1961. He overturned the thought that in biology that showed that cells do not propagate indefinitely. We know that. What kind of cells propagate indefinitely? No, good. No. Within our system, you'll see it's the cells, the eggs and the sperm from the ovary. And stem cells typically can propagate indefinitely. That doesn't mean they can be active and they can heal a situation, because it's all about that microenvironment, that milieu that they're bathed in. You can put any cell, an egg, a sperm, fertilize them, but you can put them in a crappy environment. They're not going to go anywhere. They're not going to go anywhere. You could put a stem cell in a crappy environment. nothing's gonna work. You've got to fix the microenvironment, the milieu, in order to prevent the growth of the problem that you're witnessing with the patient. So he also noted that after about 60 doublings, that's kind of max. I think that's in our hair and our skin and things that turn over rapidly and frequently, there are 60 doublings. But in other cells, there may only be 40 doublings. So if we understand that, we're going to take better care of those type of cells, right? If they just stop dividing, then they become zombie cells. The question is, can we autophagize them or apoptotic them? So what is a senescent cell? It's a cell that basically can't divide, but it's still viable. Cells that can't divide that are viable, like zombie cells, they don't do you any good. They recruit zombie cells around them. They're not the loving touch. They're the zombies in the nursing homes where that I used to work in. And I thought, well, I'm working in outer space. 30 years ago, for 10 years, I was working in transitional care, some nursing homes, some other places. And it was really just like a whole different world. And I couldn't believe, like, what is this? And that was one of the things that prompted me going from performance to this space where people might be only 30 or 40 or 50 or 60 and they're zombies and they can barely color. And I'm thinking, this can't be life. This can't be what it is. And putting people here is not what I went to medicine for, right? I loved my work there. I stayed a long time. And I learned so much by being in that environment. But cells that can't divide can still be viable if apoptosis doesn't occur. And that happens more often than we think. So when we look at another complicated diagram over here with young on the left, aged on the right, and we're thinking what happens, we have young hematopoietic stem cells that can become senescent hematopoietic stem cells. And then we get senescent immune cells. And if we have senescent immune cells that are zombie that can't do their job, that haven't been blown up, apoptosis, or autophagized, gotten rid of, then effectively they're going around and in their surveillance, because immune cells are the only cell that circulates around every cell in the body, whether it's through the arteries, the veins, or the lymphatics, or through the extracellular matrix. They are the only cell that every other somatic cell sees in the body. They travel in the circulation. So when we get immunosenescence and we end up with the senescent associated phenotype, all of these pro-inflammatory cytokines and anti-inflammatory, the challenge is, how do we resolve that inflammation so that we don't end up with so much oxidative stress and in cell death or zombie cells with inflammation and shifting? And again, the MAMPs over here with the microbiome, it's pretty challenging. Oh, how am I doing that? There we are. Okay, so I put, I know all those arrows, you don't need to see that one. So here, I like this slide as well, because if you think about this single cell layer right along here, and it's so minuscule, right? If you look at an electron micrograph, you're going to see how small this is. And then all out here is the external environment. And then right underneath this one cell layer thick, you've got the immune system ready for action, friend or foe. It's the border. This is the border. And there has to be a border between the outside and the inside of the body, right? And that border needs to be protected. One of the most important is the mouth, the anus, the vagina, anything with this beautiful mucosal membrane, right? If we start by protecting one end or the other, we're going to protect everything in here, right? So we have to think about that. But when we end up activating immunity and we end up with inflammatory cytokines and adipokines, the chemicals that are released from adipose tissue, shifting our adipose tissue, which is very biologically active, from metabolically low activity to it goes from metabolically high to metabolically low over time, but it just holds on to things and doesn't really do anything. It acts as an insulator and as insulation, and we become inflamed from the adipokines that are being released from that white adipose tissue that we would prefer to be brown, very metabolically active adipose tissue. And here you can see DAMPs and PAMPs. This is MAMPs as well. DAMPs, MAMPs, PAMPs, and all of these things affecting the SASP, affecting the NLRP3, the TLR, the toll-like receptors. You can go into the weeds with this. I think it's worthwhile to do that on your own. This is a high-level talk. But ultimately, when we've got this senescent associated secretory phenotype and we stop mitophagy and we end up with zombie cells and senescent cells, senescents aren't dead cells, they're cells that just can't do much. They're cells that just exist, but they influence in a negative way all of the cells around them, right? And then we end up with the altered body composition, the increased adiposity, the insulin elevation, the cortisol elevation maybe initially, and then hypocortisolism secondarily, and we end up with loss of muscle mass, fragility, etc. So far making sense? Okay. And now here lifelong, we want to, reduce the chronic, low-grade, sterile inflammation by understanding we're going to have inflammation. It's appropriate. But what are the anti-inflammatory stimuli and the antigenic load that we can look at? And how do we look at this antigenic load with data, but also looking at the person in front of us, then thinking about what's the antigenic load that's going on that we can measure in data? It's not really going to be just the data that we change that's going to produce the quality of health in the patient. It's going to be the relationship and how they understand these things and how they understand what they can do, right? Lifestyle medicine is a big deal now. Most doctors, I know you all talk about it, but it's a big deal. That's why I partnered with a chef, my chef business partner back in the room, Marisa Yako. She knows food like the back of her hand, and we keep it simple and satiating, etc. But nothing I do, if people can't dial in their food and eat as healthy as possible, not 100% of the time, 75-25, 80-20, it's up to them, then I can't really help them. I honestly say, I can't help you. Let me know when I can help you. I'm here. I'm not going anywhere. Come back when you're ready for us to work together. But it's not going to work if you can't work with me, because this antigenic load that comes from so many epigenetic stimuli, so much of the lifestyle, the way we think, the way we choose to behave, the way we choose to act, the lack of the sedentary nature. I mean, 10 minutes a week can be enough, but you've got to know how to do that of activity. It doesn't have to be the hardcore workouts that I did as a youth twice a day. And that was, I thought that was the be all and end all until I was 35. And then I realized nobody does this, let's just dial it back. It's not also healthy to be that way, but let's dial it back and let's just do something reasonable and make sure that its body weight doesn't have to be it doesn't have to be weights, etc. But understanding a lot of the genetics, we can look at TNF alpha genetics. We can see if people are prone to that. I know I don't have a SNP, a single nucleotide polymorphism from TNF alpha. It doesn't mean I'm not going to have elevated TNF alpha, but that's not where I'm going to look to see if I'm having an inflammatory response to something that I'm exposed to. Right? I may have a CRP elevated, you may have an IL-6 elevated, you may have a TNF alpha elevated. You don't have to go and do genetics. It will help as the price comes down, but you have to understand that just because you didn't see a CRP or an IL-6 or an ESR elevated or homocysteine elevated, there are many different markers that will all be determined based upon the SNPs of that individual, their individual genetic blueprint. And that's some of the stuff that I learned by looking at a lot of data and saying, this doesn't make sense. This isn't what the book taught me, right? So, N-glycans and galactosyls are all very important. We want to keep and protect as many of these things we can do. What are eicosanoids? Omega-3s. You can have inflammatory eicosanoids and you can have anti-inflammatory eicosanoids. So those are things that are so basic. There are many revered docs I know around the world and country that would say, if we can keep our omega-3-6 ratio, including DGLA, the anti-inflammatory omega-6, healthy, and vitamin D healthy, and just basics of movement, etc., that we would mitigate a lot of disease. Also the mouth health, right? Okay, so here's one of my favorite slides. It's a pearl. This is said pearl number 1, because this is the process of cellular senescence. But really, this is the process of healthy cell division. So we have a normal cell here, right here. It has a lot of exposures, extrinsic and intrinsic factors that are influencing this cell and what's going to happen to the cell during one of the doublings that Hayflick talked about. So looking at these, I mean, there are things that we can really change. We can alter our epigenetics. We can alter our oxidative stress. We can handle that. We can measure that. We can know that that's happening. We can just measure pH of the urine or ketones in the urine. We can measure very basic things to understand that. It doesn't have to cost a lot of money. We can understand what exposures from viral infections that people had, and we'll talk more about this in other talks this spring that I have coming up. UV light, radiation, exposing yourself and restoring. Radiation is just a form of energy, right? Light is just a form of energy. I was this weekend at another physician's office, a really trusted dear friend of mine in Cincinnati, and we were doing xenon gas inhalation. That was quite, really cool. But there's xenon, and you can use krypton gas, and there's other gases. But just in this biocharger, bringing these 6 lights together photonically, that's how we produce light. And then that light interacts with electromagnetic fields, because anything that can harm you can also help you. You can have radiation and electromagnetic fields that harm you, but you can also use them to restore. And that's what this device so brilliantly does. It's really quite remarkable. So nobody gets away without having exposures. There's nobody special. There's no secret to trying to get away from having exposures, but this normal cell will have its exposures uniquely individual to the person, and then it will go through its doubling, but at some point it will potentially become senescent, depending upon PAMPs, DAMPs, and MAPs, right? These exposures, again, just think in the 3 categories. Are they extrinsic? Are they environmental? Are they pathogens? And are they the microbiome, right? Are they those? And so this should happen. We should end up with some cells that end up becoming zombie cells. But what we really want to do is have apoptosis or autophagy, because normal physiology over here on the right is about tumor suppression, wound healing, allowing our stem cells to be activated and clearing immune cells that no longer function. But when we don't pay attention and we get hit, doesn't matter your age, you end up with microenvironment, a milieu that doesn't allow for normal physiology to occur, apoptosis, autophagy, and we end up with pathology and age-related diseases, whether it's cancer, whether it's chronic inflammation, the third one down, whether it's autoimmunity and tissue dysfunction, or senescent reinforcement. When senescent reinforcement happens and these inflammatory cytokines and chemokines and cells are not cleaned up and balanced with anti-inflammatory, we end up with affecting the cell. These senescent cells affect the cells around it in a paracrine nature, and then they affect themselves and they just feed on themselves, creating more and more zombie-like activity, which is pretty important to understand. So again, looking at this, what I like here is we have DAMPs, PAMPs, MAMs, the stressors that we can choose, not all of them, but we can choose to clean them up at any rate. We will get cell cycle arrest. We will get inflammation, the senescent secretory inflammatory chemokines and cytokines. We will get immune cell recruitment that maybe we can afford or not afford. Maybe we already have lymphopenia, so we really can't afford to have an exposure that requires more lymphocytes that we don't have available because they're already tired. And they've already had to adapt multiple times to a chronic, sterile, inflammatory state. So far, so good? With me? Anybody? Okay, so now we have what can happen. We can have senescence escape, we can have immune clearance, and we can block going to a milieu, a microenvironment. I call it a TME, a tumor microenvironment, because we've always got to be thinking about a tumor microenvironment. Angiotensin converting inhibitors, ACEs and ARBs can really work to prevent that tumor microenvironment from spreading. That's not just the cells, that's the fascial tissue that becomes scarred, creates blockages. And again, this all feeds back on itself. You can picture it, right? And so we really want to be working to prevent this TME, tumor microenvironment, by getting apoptosis, having autophagy, having immune clearance, etc. So we can use telomere length as a biomarker for aging, and this has been studied for a long time. This study was back in 2012, 13 years ago. All right. So if we think about the length of our telomeres at birth, relative risk of 1 means you have no increased risk for a disease, right? At birth, what's your relative risk for heart disease? 1. At birth, what's your relative risk for cancer? 5. You have a big risk because the cells are turning over so remarkably. But because the cells are turning over so remarkably, you know that childhood tumors are much more curable than adult tumors, right? Because they have a lot more happening, they're youthful, etc. So it's pretty cool. This is the work of Michael Fossel from the West Coast. Now I think he's left Stanford, but you can see that cancer incidence, the longer the telomere at birth, you still have a 5-fold relative risk for cancer at birth. Mid-late telomeres, 14.2, relative risk of cancer, 22.5, the shortest telomeres are going to increase your risk for cancer dramatically. So that's important to understand. When we look at MI incidence, we have a relative risk at birth when we have our longest telomeres of 1. As the telomeres shorten, at mid-length telomere, we have 2.6 relative risk, and the shortest telomeres have it. This alone is an independent biomarker for understanding very early on, you know, what's going on. Here again, we talked about this earlier. Here's telomere length. Here's germ cells, eggs, sperm, etc., stem cells. They don't really age the way our somatic cells do, right? So our somatic cells are aging, but if you're aging early, young, like the 22 and the 25-year-old I saw this week, that means that it's likely that your telomere length is not good. Is it important? So can we restore it? Of course, we can supplement to restore it. Telomerase is an enzyme that's produced only inside functioning cells, not zombie cells. It is not possible to take biologically active telomerase orally. We can take things that promote it to become more active and to promote autophagy, etc. So in 2009, again, a long time ago, 16 years ago, Blackburn, Greeter, and Sostek showed that activating telomerase in human cells reduces telomere shortening and allows older cells to begin replicating again. That's pretty mind-boggling that we can do that. We can activate our lymphocytes. We can improve their telomere length by 25+% if we know how to do that. So that's important. What is aging, chronological versus biological aging? The way that I think about it, we can look, people come in all the time and they say, oh, the age of my cardiac myocytes are 25, they're 50. And I'm like, that's fantastic. What's the age of your immune cells, right? Because if your cardiac myocytes are 25, based on some testing that you did, I would anticipate that your immune cells might be good, but I actually don't think that the testing's that good on the cardiac myocytes. So I think it's a false hope. And it's not that I don't want to give hope. I want to give hope, but I want to be realistic so that people really can understand. So people are really happy to know how young they think they are. But I say, the reality is, do you want to know what you can improve? As an athlete, I wanted to know what I can improve. The more coaches I had, the better athlete I was going to be, right? If I only had one and he only focused on what he focused on, I didn't improve more things, I wasn't going to be the best athlete. So for me, it was going to be, how can I improve as many things that aren't great? That's how I know I'm going to have quality of life, because there is always something silent and invisible that you can't see. So I don't think it's bad to focus on your strength when you're down, but when you're up, focus on what you can change. Right? When you're doing well, focus on what. And I think the immune system is really important. And the loss of homeostasis in the immune system is a really big deal. So we can see that immunosenescence, or aging of the immune system gets dysregulated, causes all of the different types of disease because of DNA damage and the inability of the nucleus, the DNA, communicating with the mitochondria outside of the nucleus of the cell through this telomerase reverse transcriptase that's trying to reduce oxidative stress. When the TERT shuttle that's communicating with the mitochondria and the DNA damage, when that gets overwhelmed, oxidative stress builds up. So again, going to the root cause, going to the most important space where something is happening is really important. If somebody has oxidative stress, which I'm sure we all measure in our patients, we know that there's immune damage, and we know that we need to address and think about the immune system and the senescence of the immune system. We talked about the inflammatory cytokines. So this is because it's the circulating tissue, as I mentioned before, it's responsible for removing apoptosis or autophagy, the damaged cells that can't undergo it on their own. And when the immune system ages, the rest of the tissue age exponentially. This is a study that was done not that long ago that showed that they basically deleted one of the proteins that encodes for a crucial DNA repair, so that you couldn't DNA repair, and which induced only immune senescence. And what it showed was that when you increased immune senescence and damage, the non-lymphoid, the non-immune organs basically were damaged as well. And that's just an important thing for us to remember. So I think we're in a decade of pathogens, and pathogens are pretty important for us to be thinking about. And that's why I think the immune system health is really critical. You're only as young as your immune system. And this came about within 2 weeks of COVID coming on the scene. It's ironic that this can happen. Don't get me wrong. I don't think it was a conspiracy theory or something, but there was something that went on with all of that, because everybody was ready to do what they did. And how were they ready so fast? But something was going on. We do need to, however, reset our immune age. The thymus gland, just like the telomeres, it involutes over time. On the left, on the bottom, you see a very healthy thymic gland. In a newborn, you can see that you're getting infiltration with fat by 7 years of age. It looks like it's 50%, roughly 75% reduction in the immune system, the thymus gland, and what it can do for the innate and adaptive immunity. And by 30 years of age, it's all about the memory. What was the memory that was induced from 0 to 17 or 20 or whatever age you were? And how are you going to hold on to that memory so that your body and your system does not succumb to any of those viruses, thinking of COVID. So this is intrinsic immunosenescence, which we can relate to as thymic involution, which all of you know, because I've done a talk before on thymic involution for y'all from a different perspective. It starts in early adulthood. 17 years old is considered. Fatty infiltration, again, of any organ. It doesn't matter what organ it is, a muscle, a liver, the immune system, the thymic gland, etc. Decreases the cellularity. We have less naive T cells. We cannot expand the repertoire of T cells to fight new viruses when we're exposed to them once the thymic gland is involuted. And that's what makes it challenging. However, if we have long telomeres in our lymphocytes, leukocytes, particularly the lymphocytes, we will be able to handle those. A virus shouldn't take anybody out, but it will if you don't have the right cells to fight it, and you've already got chronic sterile low-grade inflammation. So here we see when we're young and as we're aging, the regenerative potential, which is basically in the bone marrow where all of the cells are coming from, the white, the red, the platelets, which have all the platelet-derived growth factors. But as we shift from youth to, I'm going to call youth up to 20, from 20 years of age and beyond, from a lymphoid to a myeloid output, we increase granulocytes, neutrophils, because bacteria will kill us, and we decrease lymphocytes because we think we've already been able to train that system, but we end up with less regenerative potential with new bugs that come in, and bone dysfunction, bone marrow dysfunction. Again, another complicated slide looking at what's happening. I put these red arrows in, showing that you're getting decreased MHC from the dendritic cells, decreased phagocytosis, autophagy, decreased in ability to handle the oxidative burst or the initial attack against something that's invading, decreased natural killer cells, increased inflammatory cytokines from the macrophages. And when you're looking at a CBC with diff, just that alone and following the patterns over time, you get a sense of where your patients are. What are their neutrophils? Typically, they're fine. What are the lymphocytes doing? Given where they are today, if they feel sick today, the lymphocytes are low, they probably don't have what they need to handle that situation. If the monocytes are high, they have a lot of cells around, but they're the sages, but they're not the the feisty ones that can really handle it. So it's really important to be thinking about this. And then when we look at the adaptive immune response and we see the decreased levels in the types of antibodies that can be produced for memory, for protection, that's a whole different thing. When we think of COVID, one thing I want to point out is COVID, the infection versus mRNA vaccine is entirely different. The infection can be handled. The mRNA, where does mRNA act? In the nucleus. What is mRNA going to do? Take over the transcription of proteostasis from the nucleus. So you're going to get a whole change and infiltration of the different nuclear and DNA of your cells, and you're going to get a change in many facets. And the change can be in any organ system. It depends upon the unique blueprint of that person. Some people may get no period. Some people may get brain fog. Some people may get loss of taste or smell or respiratory. Other people may have horrible a myalgic encephalitis. So you can expect anything to happen because it doesn't depend on what we think we're going to see. It depends on what that body has to do based upon all of its prior exposures in life. But at any rate, when we have the SASP, we end up with impaired autophagy. We end up with these changes in proteostasis, with mitochondrial dysfunction as a relationship to the TERT mechanism between the nucleus and the mitochondria, because oxidative stress just builds up and damages the mitochondria, right? And voltage and energy and all of the things that we know that we try to, do with this baby, don't work. We end up with MAMPs and microbiota damage as well, because the gut knows everything that's happening in the body immediately. Immediately, we have antennae, we have sensors. Before anything happens, our body knows it's going to happen. So there's a vicious cycle between this state of immunosenescence, the aging, the zombie cells within the immune system, and being exposed to infection. And then what happens to damage within the nucleus, damage to the DNA, damage to the telomeres, the damage detector, loss of homeostasis, all the things we just saw, accelerated aging. Autoimmunity and lupus in somebody who's 20 years old is progeria, period. If you have autoimmunity and it's progressing, and the rate of your lupus or whatever connective tissue disorder you have, if it's a relapsing and remitting, and mostly it's remitted in that person, they likely have pretty good cleanup. But the person who doesn't really needs attention to autophagy and cleanup, or otherwise they will have a poor quality of life. Telomere attrition increases with the number of herpes viruses. I'm seeing a big rise in every age in HHV6, which is very interesting. I haven't found in the past many CMV, but when I see these patients coming in with COVID or COVID-like symptoms, and it appears to be COVID, oftentimes they never knew, but I'm seeing a reactivation of their CMV, which blows my mind. I never knew they had it, but now I'm seeing IgM to CMV. So that's pretty remarkable. Here's 400 subjects, older age, 53 to 76, followed for 3 years, looking at different herpes virus and looking at the primary ones, HSV6, which many people have had exposure to. The question is, can the immune system keep it at bay? Is it healthy enough? CMV, I don't think it's like EBV. I also think EBV is very important, and you can measure that now in real time to see what the immune system through interferon and IL-2, what it's reacting to, but all of these contribute to telomere attrition. This is slow telomere attrition. The number of infections that you've had in your lifetime that also can be reactivated hastens telomere attrition regardless of your age. That's pretty important. Then, depending upon your genomics, your blueprint, are you going to get cancer? Are you going to get chronic inflammatory diseases? Are you going to end up with autoimmunity? I have no cancer in my family. It doesn't mean I can't have it, but it's likely I'm going to get the inflammation or the autoimmunity, right? So we know that the molecular clocks of DNA damage can produce the zombie cells. We already talked about that. We know now, just from that last slide, about the chronic and acute reactivated viral loads, that they're very important, including other COVID and strep as well. Strep is huge. And this Chinese extract of astragalus. So CMV alone accelerates chronic immune stressor age and shortens telomeres within immune cells, because we know that these herpes viruses, any of them, live latent in monocytes that flow around in the bloodstream, in endothelial cells, So where's the endothelial cell? It's around every part of the body, right? It's just another barrier, and in the kidney lifelong. So we require continual immune surveillance by cytotoxic T cells, which predominantly are the innate immunity from the thymus gland, right? So that's the importance of the things that we mentioned before. Are you guys still with me? Okay. So, and the prevalence of seroconversion from what you kept in check as a child to what becomes out of check as you age, if you have immune senescence, the prevalence is 55% in the US and 30% in youth, but by 80% seroconversion and activating these causing disease is pretty important to understand. So CMV will accelerate the conversion of naive T cells to senile memory cells. Those are zombie cells. They're not effective anymore. It decreases the naive virgin immune cells. What can we use to increase naive virgin immune cells? What, anybody know my favorite thing in the world? Come on, Sarika, I know you know it. Yes? No? TA1. TA1 will increase, naive immune cells, and it's been studied, right? What else will increase? You take it, not TB4, you take it orally, half a day. TA65. TA65 is the specific astragalus root that's been studied that will also do that. So that's pretty remarkable. So looking here as the naive T cells, because of the thymic involution, are going to go down anyway. The question is, how functional are our memory T cells? We may have them. You may find antibodies, you may find memory T cells, but are they functional? And the likelihood is that they're not. So understanding the lymphocyte telomere age is really important. So COVID-19, blah, 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 immunosenescence may be part of the cause. It's not the cause, but it will contribute to how well people do. If people have a history of EBV, CMV, HHV6, HSV1, they're going to age their immune system up to 20 years. So if you're the 25-year-old that I saw yesterday that is so chronic variable immunodeficiency that nobody knows what to do with, I mean, the reality is that she probably 10 or 15 years ago aged to her immune system 20 years, and she looks and feels like a 60-year-old. So we've got to work on reversing that, right? And these are the things that we need to understand and how to do this. I'm not going to focus on CMV too much, but it is a negative risk factor for clinical outcome, meaning that you will not do well if you have had CMV, and that is what I find as well. It increases hospitalization and poor outcomes as well. So when you have these other PAMPs, DAMPs, and MAMPs, your pathophysiology will be accelerated, and you will end up with diminished lymphocyte telomere length, LTL we call that, lymphocyte senescence. They may be there, but they're not functioning, right? So that's the key thing. If you have a person with 48% lymphocytes when they're sick, but they're really sick and they're not getting better, you got to question the function. Number does not equal function, right? Number does not equal function. Important to know. You can see a lot of peripheral lymphopenia. I see it. I measure it. It's one thing I'm zoned in on for the last, I don't know, fortunate that I pay attention to everything. Mitochondrial dysfunction will be a component, but we're really not going to get mitochondrial function much improved. We can do all the NAD we want, but it's a temporary fix. We've got to decrease what's causing the damage to the DNA, the MAMP, the PAMP, the DAMP, in order to allow whatever we're doing at the other end of things to really have a beneficial, sustainable impact. And that's what our goal always is, right? So this is all about COVID, which COVID and CMV, there are very similar risk factors and linking them to the underlying diseases. So severe COVID was associated. You don't need to go through this. This is just telling us that we end up with reduced replication, telomere length goes down. We end up with not the same replication within the lines within the bone marrow, the megakaryocytes. You don't get as many platelet-derived growth factors. The granules within the platelets don't work as well. right? The EGF, the HIF, HIF, all of those different factors that you find in your platelets are not going to work as well, nor are your lymphocytes or leukocytes going to work as well. Short telomeres increase the risk of any infection or any disease. We already saw all that. Again, we're looking at long telomeres, and we're looking at the T cell pool. As the telomeres shorten, the T cell pool is dramatically different. Even if you have the number, and you know the number, what is the function? You've got to think, what is the function? But you can look at the person. You don't even need to measure it. You know if they're not getting better or not. In May, I have a talk up in Maine where I'll do some talks about different cases and showing some different testing that you can see. How do you measure this in real time? So this is, again, if you've got immunosenescence, you've got inflammaging, SASP, potential autoimmunity, immune metabolism that's not working well when you get the COVID-19 infection and the activation of the macrophages. And a cytokine storm is just senescent-associated secretory phenotype, right? It's the same thing. Then you're going to get fibrin deposition, and then you're going to end up with lots of a tumor microenvironment, an unhealthy microenvironment. All the herpes viruses contribute. Again, you start with the virome. It ends up affecting the damage detectors in the DNA, the telomeres. You end up with immune senescence, and then you end up with aging. Another way to look at it. So what are some enhancers that you can use? Well, lifestyle. Obviously, meditation, we all know the benefits of that. Stress reduction, music can reduce stress. Community can reduce stress. The poor dog must have a friend next door now that he's not barking. But, all kinds of things. I think community is a big one. I think some people may use faith. Some people may use meditation or music, whatever it is. Exercise. It doesn't have to be hardcore. It has to be movement. Somebody can just walk during, 50 steps after their meal, shaking their arm, 20 forward, 20 back, and do that 4 times. After each meal, it makes a big difference. It's going to get flow. They can tap. Right? They can tap. They can do a lot of things to create flow. Tap. People who can't breathe, they can tap, right? They can think about what their food is going to be. It needs to be simple typically if they're inflamed. You don't want to obviously, have the gut that's already inflamed and understands this process. You want it to be, you want it to calm it down. So you want to give it very anti-inflammatory. Not necessarily foods like complicated diets, but everything very simple that doesn't require a lot of digestion. We know obesity is a massive problem, so weight loss is a really great thing. Smoking, I don't have any patients that smoke. If I did, I would know because I'd measure the cadmium level and I can see it. So diet, omega-3 intake, polyphenol intake, low fructose, low saturated fats, low inflammatory fats, not low polyphenol fats. I mean, these are in studies, so these are not just my things. I know, I've been at dinners with a doctor who researches Mediterranean diet for telomere length. I think that's kind of silly because we know that the healthier the diet, the better the polyphenols. Why are we spending our money on that right now unless we're looking at a specific thing? Because we know, and that's why I partner with Chef, to basically just produce whatever ancestrally is going to be best and most simple for that patient. It's not only going to be about the Mediterranean diet. It's going to be about simple, healthy foods in my mind. Supplements, vitamin D, omega-3s, those are the 2 things we mentioned that could really change a lot of diseases. Antioxidants, what are they going to be? Are they going to be nitric oxide? Are they going to be glycocalyx with nitric oxide? What are they going to be? That's the question that we need to answer. Minerals, of course, are really important. Now, in order to activate telomerase, the enzyme that prevents the shortening, hormone support therapy, right, is really important. Balancing the hormones, looking at the estrogen progesterone balance, looking at the FSH and the LH and understanding where are we with this balance. Maybe you could use those numbers to determine the dose of hormone support that you're going to give that patient. I have some patients that take 500 milligrams of progesterone every day. It depends on what they need, and they do great on that. It's not always the 100, the 200. It can be oral, it can be in creams, but you've got to play with that a little bit. Cortisol, higher cortisol will decrease and you will shorten. So again, managing stress, growth hormone will improve telomerase activation. Statins have a mild impact. That's not my thing because I don't think we were born without a statin. There is a peptide statin that I love, but it's hard to get, so I won't even bother talking about it. And then, pardon me, and then there's TA65 that has been studied for 25 to 30 years in clinical trials that are peer reviewed. These are the potential interventions to induce time-restricted eating, exercise, movement, epigenetic things that we already talked about a lot that will induce autophagy. We all understand this. And those are the potential benefits, which you already know. So now thinking about a unified model of aging and where we might intervene in terms of we don't want to lose our cells. We are losing our cells because they only have so many doublings. So we have to look at this proliferation and think about how are we going to keep our DNA healthy? The damage detectors, the damage clocks, how are we going to do that? Well, we're going to try to prevent telomere shortening in any organ. But I think because the immune system is a circulating tissue, I would suggest we do that. We work there and we want to think about inhibiting this process because if we just start upstream here at the root cause, we can inhibit so many things downstream. And if we can impact epigenetic changes, we can also reduce the inflammatory chronic state, sterile state, the downregulated DNA repair, the mitochondrial dysfunction, the DNA damage, reduction of the oxidative stress. And we can also mitigate disease, just even through lifestyles along with telomere shortening. So this is the most effective target when we think about what can we do. This is for a neurological model. We could think, and being somebody who worked, I worked on an Alzheimer unit, you know, we 25, 30 years ago, we gave Aricept, we gave Namenda, we gave all of these things. They worked in one pathway. But if you really even look at dementia and the model, and I know we can measure p-tau and all of these great things, but if you really look and you really dive in, dementia is so many things. And dementia happened 30 years before it happens, right? So I think we need to be thinking about upstream if we're really going to get the most effective, sustainable, cost-effective approach, as opposed to starting every monoclonal antibody one at a time, having that kaleidoscope happen where you use this monoclonal antibody, you shut that off, they feel better. Take IBD, Crohn's or colitis, they feel better, but then they regress, they get symptoms again, you go to the next one, but there's always a side effect. So if we can intervene upstream, it's going to be most effective, as opposed to obviously the symptomatic treatments or the monoclonal antibodies. 2 cases, shall we go? Okay, everybody's fine. 62-year-old, this is a patient, he's been here for a long time. In my practice, I know him very well. He is not from he's not from this continent. He's from another continent. And a lot of my patients aren't from the States. They have different mindsets. So it's a lot easier to deal with him. He did have prostate cancer at 50. He got vaxxed for COVID-19. And then in January 2023, he presented to my office with mostly he was really complaining about his arm because it was numb. And it wasn't direct shortness of breath, it was an anxiety. I had him go to the emergency room telling them it was shortness of breath because I knew if he told them he wanted to kill his wife, then they would pink slip him. But the reality was he was really anxious and he said, I don't feel well, I don't feel well. And when I lie down in bed at night, I really don't feel well. And if my wife irritates me, I'm going to kill her. And I said, we're not killing your wife. We're going to see what's going on. And go figure, I measured some testing and found the cause of what was likely to be going on. So what we found, ultimately he was dilated with cardiomyopathy. So what do you think the test was that I did that identified? Anna? What was the blood test, Anna? Yep, NT-proBNP. And his NT-proBNP was 1500. And I had one, I always get baseline on people, and he was 80 previously. So I'm like, dude, you're in heart failure. You have to go to the emergency room. I can't go tonight. I can't go tonight. Okay, we'll go in the morning. It's a good time. It's 7 a.m. It's cleaned out. Go at 7 a.m. and here are the symptoms you're going to tell them. So we went to the emergency room. Now, this was in January of 23. In February of 25, I sent somebody to the emergency room for the same situation, right? And it was a completely different experience. He went to the Newton Wellesley. My second patient went to the Brigham, and it was a completely different experience. They didn't even know what an NT-proBNP was at the Brigham in February 25. It was a whole new group. So anyway, he got great treatment at Newton Wellesley. They basically did a workup. They kept him for 10 days. This woman, the woman that I sent in February 25, got sent home at the end of the day on a weekend alone and couldn't breathe and her heart rate was tacking away at 150 or above. It was ridiculous, right? So I wanted her to go to the emergency room, not because I thought they were going to do anything to save her, but I wanted the diagnostic testing like he got to prove what was happening, right? So at any rate, these are some supplements that he was on. He was on glutathione, which is a peptide that I use in everybody pretty much. Vitamin D, omega-3. Again, you've heard about those. I love curcumin, CoQ10. He took a nitric oxide tadalafil. He had prostate cancer, remember. He was taking transdermal testosterone, melatonin. His statin had given him a PCP, even though he never had lipids that were abnormal. This was already prior to going to the hospital. He had lost 16 pounds. He wasn't really overweight, but he had inflammation that he had to lose. And he had gone on a diet previous to this, but still ended up with cardiomyopathy. And they ultimately said, we don't know the cause, but it's likely viral induced. And it was viral induced. It had to be. They put him on the 8 drugs that they use, and they basically did nuclear medicine scans every month on him. And this is the write-up from them. He went back every month for a nuclear medicine scan. These are the events taking place. If you can resolve the inflammation, you don't end up with any dilated cardiomyopathy. But if you get this tumor microenvironment, this green collagen fibrosis tissue, which happens in the extracellular matrix in the fascia, then you're going to end up with dilated cardiomyopathy. So these were his numbers. Again, his number in January 23 of C up here is only 1.8. Not that concerning, right? You would think it would be bigger. By August of 2023, it was 0.5. But we can look here. These are the prior ones to when I began to measure. His CRP had been higher before. But remember, this was during the COVID pandemic. So he had exposures, he had vaccines, he had other things. And then prior to getting this cardiomyopathy, probably a month or 6 weeks earlier, he had gotten his 4th vaccine, right? So can I prove it? No, but it's his own story. There was no other cause because he was worked up, with the $1 million workup. His IL-6, nothing to come home. I have other people who have COVID issues or reactivation issues of CMV or other things. They might have an IL-6 of 100. Again, it's not just about the numbers that we think they should be. I'm not going to look at his IL-6 and see, 3.1 or 2.7 and get worried. I started to treat him in May of 2023. He went along with the Brigham treatment. The Newton Wellesley treatment, same diff. From January 23, he did the 8 meds until May, and he came in and he said, I don't want to do this anymore. I don't want to die. My numbers haven't changed. I go back every month, and they just say that they don't know what else to do, right? And I didn't feel good. So I did an intervention in May, and his number went up, right? His BNP was coming down, but I still don't love an 877. I didn't know it was going to go to 254 and 23, but I just had to say, what am I going to do at this crossroads? Is he healing, or am I going to make a change? And like Warren Buffett, with the tariffs that are coming and the changes in the stock market, what's the number one thing to do? Be patient. So I just said, I'm going to keep going because I've read the studies on this. I've been with the people who have studied this, particularly for the heart. They told me personally, Marisa was present, that this treatment could heal a heart, and I believed in it because I also understood it. So you can look at those labs and you can see that, he was in trouble, and he's not that old, and he has a family, wanted to live. We can look at his diff. We can see that he has great neutrophils. Lymphocytes are relatively low, but they're expected. Monocytes are high. When I see basophils and IGs, immature granulocytes high, I know there's some really ongoing things, and I know that we need to have resolution. And this was again in January 2023, regardless of the white blood cell number, the neutrophil lymphocyte ratio and the immature granulocytes and the basophils are going to give me more information. And his COVID-2 antibody, not helping him, was greater than 25,000. So in May of 23, he came in and he said, I'm not feeling well. So my team and I, the prior Anna, who was Audrey, treated him. He treated, did some injections for the numbness in his arms and his hands and his shoulder. We gave him a series of IV. We then gave him some IV peptides. We then gave him some peptides to take home, mostly TB4 and TA1 to improve the naive T cells. And the TB4 works with intracellular infections at really understanding and remodeling through particular receptors called the integrins, help to remodel the cells and to prevent fibrosis. If TB4 does anything, it's anti-scar tissue. And he had scar tissue in his heart. So we were working to prevent that. The study, and the woman that I met who did the study from Hungary told me, MD PhD, previously in the States, but then went to Hungary to do the research work, 20 years of research looking at, can we reverse heart attacks and can we make the heart function better? I have friends that do stem cells with this, but just with peptides, she demonstrated with thymosin beta-4 exogenously, not endogenously, that you can help the heart to heal post-MI, which blew my mind. So that's what we did for him. But the next day, his arm was all better from whatever, 2 days later from what we did. But obviously, it's a process to improve the naive T cells, to get the remodeling of the fibrotic tissue, to get the cardiac myocytes to be healthy again. And TB4 also works on myocytes, and the heart is just a muscle, right? So that's another thing that it does. So we discontinued his medications that he was taking from the Brigham when we started what he was doing. We did TB4 long-term, glutathione long-term, some of the other things that he did. We added methylene blue and nitric oxide. We added TA65 to boost the function of the immune lymphocytes. He continued with his testosterone. 5 months later, he emailed us on a Monday morning after getting his nuclear medicine scan on Friday. He said, as of last week, my test results, my heart's in sync. My EF has increased to 45%, doubled. In your life at the Brigham, Rich, did you ever see an EF go up from 20 to 45%? Never. Never, ever, ever. And I'm sure it still hasn't happened, especially when I'm sending people there in February and they don't even know what a BNP is. So, anyway, so I said, you did this, they did this study. Did they ask you what you did? And he said, no. I said, did you tell them? He said, no. I said, okay. He said, I'm confident that the thymosin peptides were a good help. Anyway, he's still doing better. His heart function, they stopped doing them every month. That was several years ago. He's now doing them twice a year. And his EF ranges between 45 and 50% continued. That's pretty remarkable. What's up? Intermittently, off and on. Yeah, there's no rhyme or reason to the way I do it. It's an art, science and medicine. This is the art of that. It's also about what he can afford and where he is and what he's doing, how he feels. He has to know his body, and he's great at being proactive, calling me if there's a problem or coming in if there's a problem. And that's really the only way I can work with people. They have to tell me when they're at unease, right? And then we work it. The doses of the peptides that I use relative to the doses that have been studied for 75 years are minuscule. They're minuscule. So, and the length of time, I mean, they've used the thymic peptides for beyond 18 months every day with no downside. And they've been studied since the 1950s. So this is quite remarkable, right? This is a young woman. Her parents are physicians. Her grandparents are physicians. Her aunt works here. She's not from Boston. She lived on the West Coast. She was very sick for 2 years prior to coming to Boston in August 2023. And her parents didn't know what to do, sent her here to be with her aunt. They're very much into loving kindness. The aunt, basically said, let's go see Doc and let's see if she can help in any way. Her aunt had never taken peptides with me, and her parents are traditional doctors. I wasn't really keen on getting into peptides with them because I didn't want to have the conversation, and I've been yelled at 100 times. So I tried to avoid that. But at any rate, so she came in and she had really bad chronic issues. She was suicidal. She was cutting. She was not doing well. She had IBS longstanding. She had the stomach flu in March of 2020, went to the ER visit. Who knows what it's about? It doesn't really matter because, again, there are chronic viral loads, right? Remember, it doesn't really matter because there's a history and there's a whole Dewey Decimal library system within her of every exposure she had. And she wasn't doing well before COVID. She had chronic fatigue. She had myalgic encephalitis as well, eating disorder, weight fluctuation. She really didn't have a significant eating disorder. She was an athlete. And because she managed her food so tightly, everybody told her she had an eating disorder. But I really don't think she had disordered eating once I reviewed her. She had chronic acne. And what does chronic acne tell you? Like really severe acne. What is the skin? An organ of elimination. So if you can't eliminate in one way or another, how are you going to get it out? Go through the skin. So acne is a great sign, and we can be grateful for it because it tells us something needs to be changed, right? It doesn't mean it's her diet because she really did dial in her food, but there are other things in the extracellular matrix, in the fascial tissue, right in the collagen tissue, and she was full of acne, and it really upset her. She wanted Accutane. Anyway, she had been on doxycycline for a long time, and that's another thing that impacted MAMPs, right? So she had chronic elbow tendonitis. She did lots of activity. She was on birth control. Her parents gave her oral B12 mist to help her when she was unwell prior to coming to Boston. They put her on Remeron and Reglan for gut motility. Here's her white blood cell count. When I met her in August, it's 2. This is a big deal. We need to measure these things. We need to know. She has no immune system. I don't care what her lymphocytes are. I don't care what her, monocytes are. If she has a white blood cell count of 2, this is immunodeficiency, right? So neutrophils were 16, lymphocytes were 67. That's a good sign. She's trying to fight something. We do know it's likely viral because the body is never going to reduce your neutrophils because bacteria is going to kill you in a minute. We know about Waterhouse-Friedrichsen syndrome and meningococcemia. You die in 24 hours if you don't get treated, right? So if she's living this, walking in my office, relatively functioning, and she's got a neutrophil of 16, we know she's trying to fight something that's viral. Immature granulocytes 1.7. So these were some of her other labs. Again, showing you that the labs don't always show you the problem. CRP at 3.7, that's chronic low-grade sterile inflammation. Other people could have a CRP of 100. It just depends on the person. Interleukin-6, 3.1, it's high, but it's not that high. Ferritin 36, typically I see ferritins of 300, 400, 500 as an acute phase reactant when somebody's chronically infected. Her uric acid was fine. I always look at that. Her thyroid's okay, could be better, but that's not the issue, and that's not going to change anything today. So she had chronic myalgic encephalitis. She had POTS, autonomic dysfunction, dysautonomia. This is from another friend's deck. This is the after effect of any infection where within the brain, the chemical dysregulation of the immune system and other aspects of the body that we just looked at are going to have deep central nervous system effects. And that's where the vulnerability to POTS comes. It's not just the virus, it's the chemical sequelae. The virus may be gone, but it's the sequelae that isn't able to be cleaned up that causes the problem, right? So these can be brain fog, fatigue, headaches, you name it. And it happens, effectively in the area post-strama that's deep in the brainstem here, and it's like having a central vagotomy. That's where the vagus nerve cannot function, and you're trying to figure out how am I going to improve it, but it's going to be more than just vagal nerve stimulation. It's going to be understanding how do I resolve this oxidative stress, this immune system dysfunction, because even though she had lymphocytes of 67, they clearly weren't able to function well. Right? Because otherwise she would have been better. It wouldn't have been years of this. So in the red, you can see once you get infected, all of the different manifestations of this infection. You can get peripheral nerve damage, skeletal muscle damage, again, infiltration of any tissue, muscle, nerve, joints, etc. You can have coagulopathies, osteonecrosis, any of these things. So her glutathione on measurement was less than 600. I prefer it to be over 1500. Her lipid peroxides were significantly high. We know her mitochondria is not functioning well. Here we can see she had CMV, right? You know, I wouldn't have known had I not measured this, and EBV as well, COVID, CMV, EBV, COVID. And so again, we did stepwise. I didn't initially go directly to alpha beta. She wouldn't do it anyway. She was feeling so badly. I didn't realize I let her video my call with her, or my talk when I was talking with her. Then she sent it to her parents, and then they started calling me, and I thought, I'm in trouble, right? I don't want to be having this conversation because they don't understand all of this. So I waited till they left me a message, and I realized they were very intrigued. Thank you, God. Grazie a Dio. So at any rate, we had a conversation, and they're like, thank you for helping my daughter. She ended up being extremely well. Now is a grad student at MIT, you know, able to get through all the graduate exams, get into MIT, doing all of the work she's doing, back to teaching rock climbing, hiking, spent the summer before going to MIT this fall, you know, out in the wilderness, and just really strong and feeling great. Came back, and when she started in the fall at MIT, got some sequelae that reactivated. She came back here, we did HBOT, we did very little bit of peptides because she did HBOT pro bono, and we did a little bit of biocharging, other things, and now she's markedly better. That's the report from Anna, because I don't see her when she comes and gets in the HBOT. For her to get better when? A long time. It took her a good 10 to 12 months. Yeah. Yeah, but she was sick for that long. But it's really interesting. I had another patient who had CMV positive as well, who was treated for encephalitis, really sick. I mean, catatonic, couldn't interact, was on Cellcept, a big immune, whatever. So anyway, we gave her some peptides, which I didn't want to do because I didn't know that they would work. She got better in like 3 months, 2 months. I was blown away. She went from completely catatonic, going for more ECTs, had already had 30, nothing woke her up. And she had been getting IVIGs, nothing woke her up. And she had been sick since 2022. I met her last summer in 2024 by Thanksgiving, met her in July by Thanksgiving. She was like, thank you so much. It's a terrible day, but I'm happy to be able to enjoy a terrible day, you know, and to be engaging with it. She couldn't drive, she couldn't do anything. You know, it was pretty remarkable. Alpha beta. Yeah. So telomeres protect the vital information in our DNA. You really should know this chart, and you should really be thinking about how you're intervening with the person in front of you for this chart. You should really be thinking about how you're going to get upstream, particularly with immune cells, reactive oxygen species, to improve mitochondria, etc. And we met all of the objectives. Thank you very much. So it is 7:54. And I want to stop the share so I can also let the people that are on the Zoom be present. And, you know, I'll take a few questions until 8 o'clock. So anybody have any questions? Great. Anybody have any questions about anything at all? Energy, voltage, frequency. Every bug has a frequency. Those frequencies interacting cause us to be sick. That's something Dakota can speak on if he wants to. But anything I can do to help, let me know. I'm trying to get back to, where's John? Tove John. Get back to this screen. Here we are. I got it. Let me see if there are, I got it. Questions. There is a recording. You can get the recording from Chris.
Yeah, I'll put it on the Facebook page.
How do you navigate the legal restrictions related to injectable peptides, as well as the sterile shipment restrictions in Massachusetts? Both thymosins, for sure, are orphan drugs. They can be used for other reasons. We can use it once something is FDA declared, you can use it as an orphan drug at your discretion in the art of medicine. So I don't really feel the need to get around that. I don't communicate or help or guide people to use peptides that they bring to me because I don't know where they come from. I don't know what they are, particularly if they're a powder. And people bring me peptides all the time saying, how do I use this? And I say, you have to call the person you got it from. It's not my peptide. I don't know what it is. I don't know how you use it. I can't be responsible for that. So I take that seriously, and then they get to choose what they do, right? So that I don't really have any concerns. There are FDA cleared pharmacies throughout the states that can ship these peptides to us effectively. Thymosin alpha-1, thymosin beta-4 just finished clinical human phase 3 trials and has been through phase 3 trials as well. So that's also an orphan drug. It's FDA. It's not approved for prescriptions that I use it for. It's approved for eye disease.
Yes, it's off label.
Yeah, it's have been through phase 3 previously and presently, just finishing up the trials. Yeah. If something's approved in another country, like the secondary trials for thymosin beta-4 for eye health, they left the States? They used to be working with Kresge Eye Institute. They went to South Korea. They're now doing their trials there. But if it's approved in South Korea, it can be used here. The FDA will allow it to be used here as an orphan drug. Let me see if there are any other questions here. No, you can take oral peptides, and Chris can vouch for the fact that even oral peptides can make a big difference. Many of you have probably tried oral peptides. I use oral peptides as well. Again, it depends on what the person's problem is, how big the need is, how big the need for absolutely getting it. If you've got a gut dysfunction, I mean, how am I going to get it through your gut? What do I feel good about giving you an oral peptide that might cost $150 versus an injectable peptide that's going to cost $150? Cost effectiveness, therapeutic effectiveness are things that I'm always weighing depending on the patient in front of me, right? So I know the cost of one thing, I know the cost of the other, and then I'm always going to be looking at what's going to be the most cost-effective way to give this to the person that they're going to get the best benefit in the safest way as quickly as possible so that we can build on, right? It's strategizing. You don't win any game in the first minute of the game. You win it not even in you can be the Celtics and be 59-24, whatever they are, but in the end, the championship is what matters. So, and that's what you can even see in the numbers of the gentleman that was 62 with the cardiomyopathy. You're just playing with these numbers. The numbers don't change the quality of the person's life or the length of their life. That 100% is known. That's not me. That's, studies that look at them all. And you can talk to docs that are, the chairs of the departments. The numbers don't change the quality of health in a person. What changes the quality of the health in the person is the intervention that you're sticking with that is at the root of the problem, right? Yeah, how did I go from Western medicine to this? It's a journey, right? You go from the path lab, the morgue, where I was in the DOD in 1985, and then I went from performance to DOD to pathology in the morgue to primary care to end of life care. You see it all and you think, what am I going to do to make a difference? And how am I really going to help somebody? Because this is what I went into medicine for, right? And so you find your way, but it's just going down those rabbit holes and coming out, going down and coming out. And that's to answer the question online. And that's the last question. Thank you for being here. Thank you for your attention. Thank you for coming. Thank you to all the hosts, all the sponsors, Johnson, Chris, Leah, everybody. I'm sure I'm missing somebody, but thank you to all of them. Thank you to Anna for staying. My business partner, my partner, Chef. Thank you to all of you. Dakota, thank you as well. Thank you all. Okay. All right, I'm signing off, gang, whoever is on here still. So Chris will be able to handle any questions that you have going forward, or Johnson's drug. Sound good?
That's cool.
That's cool. Then he said,
Yep.
arrivederci.
Oh, one
one-
reminder, there is a gallery event coming up next Thursday in Burlington. So I'll send out the reminder, and Dr. Burns is going to be doing the presentation. So it's great free
What's the topic?
education. It's on cancer,
Cancer.
screening through gallery.
Oh, multi-cancer early detection
That's right.
on the AMO.
So we're trying to spread the word for gallery through Greater Boston Functional Medicine as well. So please attend if you'd like.
Awesome.
Thank you.
Ciao. Thank you all.